Good evening and welcome to Grand Rounds. Now that I'm no longer department chair, they didn't tell me that they moved Grand Rounds, so I went to the wrong room. uh, so it gives me great pleasure today, to introduce our speaker. In 1995, was that about right? Or was it 94? That you came to Mount Sinai as a fellow? 93, okay. So Sean Morrison was recruited in 1993 to Mount Sinai after having completed his residency at New York Hospital as a fellow by the first chair of this department, Bob Butler. He joined the faculty as a junior member of the faculty and was recruited here by the second chair, Chris Castle. And it was my, pleasure to promote him to professor subsequently when I became chair, and to a variety of other roles, in the department. Now, it is no secret that I wanted my succession to be internal. From among our faculty, among which I thought we had a number of candidates who could be the next chair. In order to sustain the progress, that we have built together over the last 15 years, as much as I expect, some change to occur, and I welcome change to occur, I thought that it would be useful, to have some continuity, with what we have accomplished together. We have seen, what can happen, when a new leader comes in and wants, as their first act, to repeal everything, that their predecessor did. So in that regard, Sean is a great choice, and I thank the dean and the school for making that happen. Since fellowship, he has really emerged as a national and an international leader in geriatrics and in palliative medicine. His many accomplishments, I think those of you in this room already know, and I'm not going to reiterate them, since I already started a few minutes late today. But it's my pleasure to introduce him. Now, I asked Chris Castle, to comment, a little bit on the day, and she wrote to me earlier today to relay, her fond greetings, to all of you here, and her confidence that the department will continue to flourish at a critical time for the field of aging and the health and well-being of older people. And she closes by saying that she's so proud to have been part of this extended family, as I intend to continue to be. Thank you. Please welcome Sean.
Thanks. Thanks, Al. As Al said, I certainly don't have any plans to repeal and replace, and seeing how well that has gone in other places. But no, seriously, it's a tremendous honor to assume the chairmanship here, and to really think about the next stages of this department and our role both within Mount Sinai, but also more globally with our role within healthcare in the United States. And what I wanted to do this afternoon is really do four things with all of you. First, I wanted to go back and do a little bit of a history lesson, because one of the very, I would say, I wasn't going to say positive, but that's not the wrong word, pleasurable things about thinking about this job was thinking back at the leadership that had come before me, and also realizing that, as Al said, I'm now one of the oldest members in the department. I can count on one hand now the number of people who have been here longer than I have. And that's it. It's Judy Howe, it's Diane, it's Kathy Devens, and it's me. That's it. So we're going to do a little bit of a history. I want to talk a little bit about where we are right now in healthcare and the challenges that we are facing. It's a review for all of you. We're going to talk a little bit about what I think we need to do to move forward. And then finally, I'm going to close with sort of a broad vision about what I hope we're all going to be accomplished together. And I recognize that I'm also talking to the VA, to CAPC, to Martha Stewart, and whoever else has go-to meetings. So welcome to the auditorium. So I don't know how many of you know this, but geriatrics started at Mount Sinai. In fact, this is Dr. Nasher, who coined the term geriatrics in 1909. He ran the Mount Sinai Ambulatory Clinic, coined the term geriatrics in 1909, and in 1919 wrote the first textbook in geriatric medicine. We were also the first training program of geriatrics in the United States. Les Lebo, right here, opened up the first fellowship in 1972 at the Mount Sinai Hospital Center in New York. He then subsequently moved it out to Long Island and then brought it back to the Jewish home when he was recruited by Bob Butler. And if anybody's interested, this is still, you can find his description of why a geriatric fellowship training program was important in the 1976 Annals of Internal Medicine. But the real founder and father of geriatrics is Bob Butler. Bob was the first director of the National Institute on Aging, wrote the Pulitzer Prize-winning book, Why Survive? Being Old in America, where he coined the term ageism. And he was approached by Tom Chalmers, the dean of Mount Sinai, to advise him about starting a program in geriatrics at this institution. Bob convinced the dean that they didn't need a program. What they needed was a department, and secured funding through the Ritter family and what was then the Schwartz family, the Brookdale Foundation, to establish the first department of geriatrics in an academic medical center in the United States. And then they recruited Bob to run it. This was the faculty in 1984. I suspect you recognize one of them. I would like to point out that these three, or four, are the practicing clinicians. These are the scientists who never saw a patient in their life. The white coats. And Bob, let me come back. Bob was a brilliant innovator and looked at the field not as both the role of this department, but took this job thinking about what is the role of this department in changing policy in healthcare in the United States. And he is now recognized, deservedly so, as really the father of modern geriatrics. But this department also owes the palliative care side to Bob. Because in 1994, George Soros, and sorry, I forgot that didn't copy well, put out a call for proposal on the Project on Death in America, whose focus was to transform the culture of dying, we'll talk about that later, in the United States. They had a number of programs, but one of the early and the most innovative program was what he called the Faculty Scholars Program, where they would take academicians from medical schools throughout the United States and give them 2 years of funding to develop palliative care within their institution. In 1994, when the proposal came out, I remember standing in Annenberg in Jody's office with Diane, and Bob coming in and turning to Diane and saying, "I have never told you to do anything before. I am telling you now, apply to this program." I'm not sure he never told her anything before, knowing Bob, quite honestly, but, and we did. We went in as a team. You can see Bob was actually on the initial advisory board to Soros. So palliative medicine was his program. Jane Morris, who was not at that retreat, Diane and I, Judy Ehrenheim, who was a faculty member here, this was the first group of the Project on Death in America faculty scholars. And what that money did was allow us to do 2 years of faculty development in this institution, essentially laying the groundwork for the development of clinical palliative care programs in the United States. Bob mentioned Chris. Chris was the second chair. Chris was the reason, actually, I went into geriatrics. She was division chief of geriatrics at the University of Chicago, and also ran the geriatrics clinic there, where I did a 4th-year rotation as a medical student. I was supposed to be 2 weeks, and I turned it into a 2-month rotation. Chris actually was recruited with Diane from Portland in 1982 to start the department, and then she subsequently went to Chicago, and we recruited her back. Chris's first major recruit was a woman named Roseanne Leipzig. You will see that the hair has changed, but the smile has not. From St. Vincent's. And what was so important about that recruit, and so critical, and I think this is key to this department, was the major investment that the chair was going to make in education. Because Roseanne came as a professional educator. She was not a clinician scientist who taught on the side. She was not a big C clinician who did 10 to 20% of teaching. Her job and her role was to be a full-time educator and to build the educational program in this department. That had never happened before. And it was also an unusual early recruit because at that point in the culture of this medical school, we were still very, very heavily focused on the clinician investigator. In fact, the clinician educator pathway for promotion developed just before you came, Roseanne? After. Before. Roseanne was the first tenured professor promoted on the clinician educator pathway. And this was Chris's vision. 1999 was a big year for us. The Robert Wood Johnson Foundation came to Mount Sinai, looked at Diane, and said, we need to develop the Center to Advance Palliative Care here. Can you give us a budget? Diane gave them a budget that I think had 5 figures to it, and they told her they were off by at least 2 to 3 magnitude. CAPSI started in 1999. The GREC, again, one of Chris's major roles when she came to Mount Sinai was to revitalize the Veterans Administration program, which had really sort of fallen into disrepair over the decade beforehand. And in 1999, the Geriatric Research, Education, and Clinical Center was established at the Bronx. And in 1999, Benjamin and Lillian Hertzberg established the Hertzberg Palliative Care Institute with a $15 million endowment. This is actually the fifth, I think this is 2003, it's the 5th year anniversary of this. Notice Diane's drinking water, Jane Brody's drinking water, Mr. Hertzberg has a drink. And in 2003, the 3rd chair was recruited to this department, Al Sue. Al came to Mount Sinai in 1995, not really by his own choice. Al was the Deputy Commissioner of Health for the state of New York under Cuomo. Does anybody remember what happened back? Yeah. He lost to Pataki. As Al has told the story, he woke up, and tell me if I've got this wrong, it was a beautiful day in upstate New York, absolutely gorgeous, and all the upstaters came out to vote. So he lost his job, but fortunately we got him. 2007, we opened the Martha Stewart Center for a Living. And again, why this picture? Because Mount Sinai put it on real estate right dead center in Madison Avenue. Again, making the commitment that they made back in 1980 with Tom Chalmers to the care of older adults. We got prime real estate. And in 2010, we got the Pepper Center. Sorry, all the Pepper Center photos are so boring. This was, again, a major accomplishment for the institution because what it did was it put us in the group, the top of aging research in this country. And that has been successfully renewed already. So what's happened over the course of Al's chairmanship, aside from the fact, it's been long enough that we've gone from black and white to color? And I'm not going to talk about the hair. So actually, in all seriousness, I just want all of us to pause for a minute and reflect on what has happened in the past 15 years in this department. We have opened the Martha Stewart Center for Living. The Wiener Family Palliative Care Unit opened on KP6. The Mobile Acute Care for the Elderly team became the first MACE team concept in the country. The Mobile Acute Care team brought hospital at home. Nobody should be calling me during grand rounds, particularly from Toronto. I think that's my father, actually. We reinvigorated the GREC due to a little bit of perhaps mismanagement by the former director. We were in danger of losing it. No institution has ever lost a GREC. We saved it. Actually, Al saved it. The National Palliative Care Research Center got established under Al. The Pepper Center got established after 3 futile attempts. Look at this, NIH funding. When Al became chair, there were 3 NIH-funded investigators in this department. There are now 9, and I've excluded the VA funding, and I've excluded foundation funding. We went from $3 million in NIH funding to $15 million in NIH funding. We had the Reynolds Center. CAPSI went from a staff of 8 to a staff of 32, and brand new space out of the basement, actually, I'm sorry, the first floor, up into Clinton space. We developed the largest geriatrics and palliative medicine, both fellowship programs in the country. We have the first integrated geriatrics and palliative medicine fellowship program in the country, and the CME course now makes money. Well, it does. We are, by our peers, this is the specialist recommending, ranked the #1 geriatrics hospital in the United States. Why we're not #1 on the big scores is because, well, Mayo, largely because of factors not under our control, specifically hospital mortality for those over the age of 65. But consistently, our peers rank us as the top program in the United States. And this is our department. When we started, it was 1 over here. And this is the size of our department. If you think back to that early 1984 slide where the department could sit in the front row here, I got told that we had to move to Goldworm because, God forbid, we would fill 1030 and there would not be enough people. So let me just stop and recognize Al's incredible achievements as chair. I think the only thing that I regret about taking this job is I don't get to work for him anymore. Thank you, Al. I'm getting told to move on. So let's talk a little bit about where we are now. And again, those of you who have had the misfortune to hear me speak before, these are going to be very familiar, but there's only 4 of them. The first is the population demographics. When I started at Mount Sinai, back in 1993, when Diane was here in 1980, this was sort of what we were thinking about. This is reality. I turned 65 in 2030. At that point, we will have squared the aging pyramid. We will have more older adults than children being born. And we will have an economic base that used to look like this to support this group of people that now looks like this. Also in 2030, the number of persons over the age of 65, actually it happens in 2025, will be greater than the number of women aged 25 to 54. Why is that important? Who are women aged 25 to 54? They are caregivers. They are caregivers. And in fact, in 3 years alone, we will have 1.2 million Americans who will not have a single relative to care for them. And, you know, we're spending a lot. This is our healthcare spending, and, you know, unfortunately, it keeps going up. You know, there was this nice little sort of dip right here where we saw it start to level off for 1 year, but it's continuing to go. And, you know, at some point up here, we're going to go over the 20% of our GNP, so that one of every $5 in the United States will be going to healthcare. But it's only a small fraction who are costing us money. You know, if we look at the top 1% of spenders, you know, 3.1 million of them spending $307 billion, and on average they're spending almost $100,000 per year. Compare that to the 156 million down here who are spending a total of $37 billion, just about 1/10 over the course of the year. So who is this population? It's the people that we take care of every single day in our clinics, in the hospital, in the MACT program. It's the people with one or more serious illnesses, multiple chronic conditions, dementia, frailty, functional limitations. And indeed, I wish I could say that, you know, this was all confined to the last year of life if we could actually know when that happens. But thanks to the good Dr. Kelly and Dr. Aldridge, we know that that is not the case anymore, and it happens year after year after year. Thanks a lot, guys. So, you know, it is a really good time to be in this department. If you think about it, we have never been more needed, and the opportunities have never been greater. But the challenges are also pretty significant as well. And there are 4 of them. And this is what I think we need to be doing over the next 5 years. We have a workforce problem. We have an evidence-based problem. We don't have an evidence base. We have an infrastructure issue. And we got a public relations problem. So let me just go through that very quickly. As of 2017, it's estimated that there are just over 7,500 palliative medicine physicians in the United States. We estimate that now, because of retirement and a decline in fellowship applicants, there's about 7,000 geriatricians. 14,500 of us in the United States. That means there's one palliative medicine physician for every 1,700 people living with serious illness. There's one geriatrician for every 6,000 individuals over the age of 65. We are training about 325 palliative medicine fellows per year, and according to the American Geriatrics Society, we're training about 75-ish fellows per year. I know, I found that strange too, but that's what they said. It's not enough. It's not enough. We have an evidence-based problem. You know, this is the number of research publications in palliative care compared to the number of research publications in oncology And just to be fair, I limited the oncologists to studies of human beings and clinical trials. Let's look at geriatrics. We think we have a stronger evidence base here, but look at what happens when you actually go back and look at the original studies on which we are basing our clinical decisions. Older adults account for 60% of all new cancer patients, but only 36% are enrolled in trials or are represented in trials. 1985 to 1999, in all the heart failure studies, this is when ACE inhibitors came out. This is when we found out that beta blockers were actually a good idea in heart failure, for example, as opposed to what I was taught, which is you never give them. Look at the mean age of people in that study. 61. That's very, very close to my heart. Alzheimer's disease. Think about using acetylcholinesterase inhibitors. Where is the population of people with dementia? Let me tell you, it's not less than 75, which is what the mean age of people enrolled in the acetylcholinesterase trials is. And then finally, this is the biggie, right? We all see depression in our practice. If you look at any of the pharmacological trials in depression, less than 10% of subjects enrolled in those studies are over the age of 65. You know, it's sort of no wonder that we're discovering side effects as we go, over and over and over. And I would argue that that's really not the type of care that we want to be providing or the evidence base that we want to use for our patients, certainly not what we want for our family members, and it's certainly not what we would want for us. We have an infrastructure issue. You know, when you look at where are geriatric programs in this country, they are almost exclusively located in academic medical centers. It is highly unusual for you to be able to find a strong geriatrics program outside of the major teaching hospitals. And let me tell you, although we live in Manhattan, and there are 1, 2, 3, 4, 5, 6 right around us, most people in this country don't have that access. If you look at palliative medicine, for the most part, it's all in hospitals or it's in hospice. And most of us would agree that if we're living with a serious illness, we probably don't want to spend most of our time in the hospital. But that's where the clinical teams are right now. And we got a messaging problem. You know, this is how we have marketed palliative care to the world up until the mid-2000s. Before I Die, Means to a Better End by the Robert Wood Johnson Foundation. That was the public relations campaign. Laugh now, but 15 years ago, this is what we were putting out to the public. Dying well. Now, what's the opposite of that? Dying badly. You know, I'd just prefer not to die, to be honest with you. Good, bad, indifferent. Let's think about geriatrics. What is the message that we are sending out there? End of Alzheimer's disease. Successful aging. So what does that mean if you don't follow Jack's book? Love this one. Keep calm and cure. And the Center for Successful Aging, all of those who are aging unsuccessfully do not apply. What's the hidden message here, folks? What are we telling everybody? Well, you know, we're telling them that we are going to successfully square the aging curve beautifully. And that if you are going to age successfully, you're going to have perfect function right up here, and then, whoops, there you have your heart attack. Actually, what I really think we're telling people is with enough investment, with enough resources completely on the cure, and don't get me wrong, I would love to be able to cure disease, and I would love better outcomes. But the reality is we are all going to be caring for a population of people for whom cure really isn't going to be an option, who are going to be living with chronic disease functional limitations, and cognitive impairment. And I think we owe it to that population to ensure that they have the best quality of life they can, and that we need a rebalancing of what we're doing here. I have the privilege of talking about palliative care to lots of individual audiences, cardiologists, Alzheimer's associations, cancer, did nephrology this year. And every single meeting, you know what? They are completely convinced that we are going to cure all those diseases. Let that sit in your mind for a while. So then what happens? So, as I said, one of the real joys of thinking through this job was to look back and think about what Butler, Castle, Sioux have accomplished. And it's pretty incredible. And I think what is slightly nerve-wracking, perhaps terrifying, is the responsibility of taking that forward with all of you. So in the last time we have left, let me lay out for you a little bit about where I think we need, or what I'd like us to be doing together over the next 5 years. This was the strategic plan that all of us put together, I guess about 5, 6 years ago. We exist to advance health and healthcare for older adults and those with serious illness. We value transdisciplinary teams, families and caregivers, and integrated research, education, and clinical care is the basis for our excellence. And our vision is to transform the health and healthcare of older people and those with serious illness. That's what we're going to be doing over at least the next 5 years together. I have a few guiding principles. For those who know me, we cannot have a talk without a sports slide and without one of Wayne Gretzky, and for those of you who heard this before, tune out. When somebody asked Wayne why he was so much better than everybody else, he said, it's pretty simple. I skate to where the puck is going to be, not to where it's been. That has been the visionary leadership that has characterized this department since 1982. And I think that's what we need to do together moving forward. He also said that you miss 100% of the shots that you don't take. And we should not be afraid to take risks together. We should not be afraid to experiment. We should not be afraid to take on a challenge because it's too big. And we should not be afraid of failing every once in a while. If we don't fail, it means we've never taken the right amount of risks. My second theme. This is probably, and we can argue about this, the greatest rock and roll band that has ever existed. I know, there may be some back and forth. Some people would say the Beatles. But in terms of sheer showmanship, live performances, and music, this is probably the greatest band that has ever been around. But if you look at them, Mick Jagger, the front man. Mick is amazing, but he's not James Brown. Ronnie Wood, brilliant guitarist, brilliant blues guitarist, but he's not Eric Clapton. Charlie Watt, great jazz drummer, who actually they brought in because they couldn't afford somebody else. Always considered one of the greatest drummers living. He's not Ginger Baker. Anybody know who Ginger Baker is? See, yeah. Brilliant drummer, played for Cream, among others. Where am I? Keith Richards. Again, do I wish I had his talent? Absolutely. But watch Keith play and then pick up on YouTube an old video of Jimi Hendrix and tell me who's the better guitarist. And yet, together as a team, despite the fact that none of them is the best at their instrument or voice, together they have created probably, certainly over the longest period of time, some of the greatest rock and roll music that we have. That's how I see this department. And the reason that I have stayed since 1993 is because of the fact that we may not have, the leading researchers in every individual field in this country. We may not. I think we do, but people argue with me about that. But together as a collective department, I think we have done more for older adults and those with serious illness than any other group over that same period of time, and it's because we play like these guys. So, 4 goals for us. The first is, let's continue to build patient-centered care rather than specialty-delivered care. This is what we see outside of our institution. This is not what I would like for us. We need to really think about this group in the middle and how we together, as a diverse faculty, as a diverse staff, as trainees, can ensure that the most vulnerable, the highest need, and indeed the highest cost population get the type of health care that we would want for ourselves and our family members. And we need to be able to do that together, because even at 15,000 physicians in the country, we're not going to be able to do it. The second thing, we are now in a time where the reimbursement system has finally changed to the point that we have the opportunity to bring care to our patients and our families rather than bringing them to us. That is what I would like to see us do. I'd like us to be able to identify the sickest and most vulnerable population before they hit our emergency department, before they have a crisis, so we can intervene when it's needed, or even before it's needed. I'd like us to think about how do we expand our existing clinical services, or indeed develop new ones that meet the needs of this population. A high-risk, high-need ambulatory practice, home-based palliative care, the MACD or Hospital at Home Plus, or whatever new name Dr. Sue has decided on. What is the new name, by the way? Hospital at Home Plus. And I think, we can have the greatest leverage if we embed ourselves within our colleagues' services, so that we don't have to take care of every single older adult that's out there, but that we can be in a primary care practice. We can be within an orthopedic group where that our expertise not only can take care of the most complex, but we teach there on a daily basis. And we address the fact that, all of us had very little training in either geriatrics or palliative medicine until we hit our fellowship programs. This is a busy slide, thanks to Amy Kelly, who I think drafted the first version of this. It's been added to. This is what I would like our clinical programs to look like by 2022. I'd like us to have developed very strong, embedded consultation and co-management services within our hospital that integrate within primary care. We have our inpatient unit. I would like us to be able to have acute palliative care at home, hospital at home. Al and Linda DeSherry are working on that. Do a better job at our transitions. Continue to build the leading visiting doctors program in the country. In some ways, refocus our ambulatory services on the people that need us most. Those are the high-risk population, the very, very complex for whom nobody else can do the job that we can do. But at the same time, I'd like us to think about how we can be embedded in other practices so that we can co-manage or consult, so that we can spread our knowledge to those who are have a workforce to take care of our population. You know, we have struggled for many, many years to build a valuable relationship with our nursing home partners. I am optimistic that we will be able to do that. This is, you know, the most vulnerable, the silent population that nobody thinks about, that is increasing year after year after year. Let's prove the value of what we do. The strength of this department has been in its clinical research and our ability not only to develop new models of care, new models of healthcare delivery, but to scientifically evaluate them and disseminate them. This is an opportunity for us. You know, I would say that we have pioneered population health research in geriatrics and palliative care. I would like us to expand that. We need R01 funding. We need more R01 funding. That is critical. We have a diversified portfolio in the department, but a big part of that portfolio is the money that we get from NIH funding. We've put in a large center grant. We need to get that funded. And Al, you need to renew the Pepper Center when it comes up. One of the things that I asked for and received from the dean in my negotiation was support for a research fellowship to bring in 2 people each year to spend an extra year learning research so that we would not have to build that on the backs of philanthropy, that becomes an integral part of our program. We need to begin to doing that. I've asked Melissa Aldridge, who's the new Vice Chair of Research, to really start thinking about that right now so we can start thinking about next year and the year after to begin recruiting. We have the best faculty in the country, bar none. UCSF tries to argue, but you know, when you line it up one by one by one by one, can't do it. Not that I'm competitive. But we need to think about how we are going to continue to grow that. You know, Al set a really high bar. Tripled the number of NIH investigators, increased the dollars 5 times. I'll settle for 50% by 2022. You know, I will settle for doubling that. And then finally, and critically important, if we don't address the workforce by our training, by producing the next generation, and re-educating those who are in practice, I do believe we will have failed. Because our role within an academic medical center is not only to care for the population in the greater New York area, but to ensure that everybody in this country has access to high quality care. So we need to create leaders through our fellowship training program. And specifically, we need master educators. We need system leaders. We need to be able to produce the person who is running the population health program for a large health system, because only they know what the needs are of the geriatric population. We need to produce the policymakers. You know, I kid Al about how he got to Mount Sinai, but think about what he did to get here. He gave up a tenured professorship. Those don't come easily, folks. To move to Albany and move into government, recognizing that his career could end with a bad election. Now, usually you think it's pretty safe in New York with a Democratic governor, but not all the time. So we need to be able to say we are going to take that risk and we are going to influence policy. We need to create the models of care delivery that drive, that improve the population, and we can scale nationally. And, you know, for so long, we have beat our heads against medical school reform. We've got to crack this now. How many of you learned about 20-year-old or 30-year-old kidneys in your physiology course? I'm speaking to the physicians. All of us, right? How many of you have ever seen a diseased 30-year-old kidney? You know, we're learning, the surgeon. You know, we're learning a set of knowledge and skills. And we're teaching a set of knowledge and skills that actually is a complete mismatch for the population we're caring for. And we need to think about how we are going to make this happen. You know, CAPC has done an unbelievable job in scaling palliative care throughout the United States. There is no better model of social change that I can think of, ever. I mean, Diane has built just an unbelievable model of what it takes to move a field from 0 to 60 in a very short period of time. How can we do that for everybody with serious illness? And what is it going to take? And one of what I would really like to see is, as we begin to move forward, to have a much tighter link to CAPC, because there is so much to be learned from that organization. And we haven't taken enough of an advantage of that. And, you know, my goal is, quite honestly, that by 2027, we will have inserted geriatrics and palliative care into the genome of American medicine. I wish I could say I'd come up with that, but that actually is Rosemary Gibson's from Robert Wood Johnson. But it's a great quote. And I think that over the next 10 years, that really should be our goal. That the care of the seriously ill and older adults should be routine, because that is the people that we're seeing. And those are the people who need us and our healthcare system the most. So, bear with me. Where is it? Part of, going back for this was thinking and reflecting about Bob Butler, who I really had the privilege of both calling a mentor and in his later years a friend, and thinking about what he has accomplished for older adults in this country. This is Bob speaking at his investiture as chair of geriatrics at Mount Sinai in 1982. And I just want you to both think about what's still relevant, but also how far we've come since Bob became department.
This is the century of at least one great triumph, the extension of life, the prolongation of life, by 26 years since 1900. That is almost equal to the advance in average life expectancy from the time of the Bronze Age, 3,000 years before Christ, when the average life expectancy was 18. By the year 1900, 47, and 73 today. An extraordinary achievement. But there are the naysayers, the gloomy souls, who do not appreciate nor understand the significance of this dramatic change, and who despair over our ability to respond to some of the challenges posed by the prolongation of life. There are some problems of adjustment, of course. There always are when there's a great social change. And there will be changes necessary to adapt our society, indeed the world's societies, in order to provide a decent old age with adequate income, with effective health care, with social roles of substance. But we will adapt to the worldwide maturation of societies. Today, however, I only want to speak, and then only briefly, about some of the health aspects, specifically the role of our healthcare system and the role of academic health centers to the changing demography. Many of the nation's health institutions and academic centers will have their eyes upon us. I, for one, do not suggest that they reflexly imitate us, but I do hope that we will become somewhat of a useful model to them. We could fail here. That is certainly a possibility. The difficulties confronting us are very real. The nation's economy causes anguish and leads also to remarkable and painful reductions in federal support through Medicare and Medicaid. Moreover, the nation's medical insurance programs do not favor the flourishing of geriatrics. Even Medicare itself, ironically, in the way in which reimbursement structures are articulated, do not favor the development of this field. Failure would be a rude interruption indeed to the present progress of gerontology and geriatrics. For now we are able to intervene in significant ways in the processes of aging and the problems of aging medically and socially. Now, although 84% of the American public, by all polls, do not want any reductions in Medicare, we will probably be faced with significant changes which will alter reimbursements to hospitals, to physicians, and to nursing homes. Such changes could be disruptive, but I am hopeful that this hospital will help prepare the way in minimizing the degree of such disruptions. For we must learn more cost-effective but quality-assuring means of assessment, better pre-discharge planning, shortening of hospital days, but without sacrifice of care. I could go on, but time does not permit. We all understand, I think, that at a deeper level, there's a sense of threat, anxiety, fear, denial, dread associated with our growing old. I even sense, and I think perhaps we all sense, that those who express the issue and organize the concern about aging draw certain anxiety toward them. A little bit like shoot the messenger. It's painful for us to call upon the country and its institutions to be concerned about something so extraordinary as the psychology, the dynamics, the fears associated with aging. That is a real danger because we could put off the challenge. We could lose sight of the linkage between our present selves and our future selves. We could continue to think of older people as some alien group, inhabitants in some other land. I have never counseled morbid preoccupation, but I urge prudent attention. It is a matter of self-interest for all of us. We dare not fail at Mount Sinai, and the nation certainly must not fail to support the development of geriatrics and all of the concomitants I've mentioned. There are generations at risk if we do. The present generation, certainly, but also your children and your grandchildren, the post-World War II baby boomers, 76 million strong, who will crest out about 2020 to 2030, when 1 out of every 5 Americans, 1 out of every 5, 20%, will be over 65.
Thank you all very much. Happy to answer questions.